PWT, HBOT, biologics, PDGF, cellular therapy, ECM, etc. you prefer. Dr. Kesun already addressed some of them. Is there any order of preference in this case?
So the basic guideline is in first 4 weeks, if your wound surface area is not decreased by more than 58%, I'll repeat again, first 4 weeks, if my wound, whatever I'm doing, my antibiotics and offloading and other things, dressings I'm doing, more than 50% reduction in the wound area is not there, then I have to reassess my technology, my treatment plan, the modality of treatment, what I'm doing. Either I'm missing on osteomyelitis, either I'm missing on the antibiotics, I'm not giving that proper according to the cultures. Either my offloading is not proper, patient is not following, or compliance is not there. The fourth question could be, I'm doing everything best, my dressings are not proper, I'm not using some moist wound healing or whatever agenting therapies I have to use. So something I'm missing out, or my vasculature is not there, ABI index is lower, and I'm still treating that by normal dressings and all. So first 4 weeks of my treatment will tell me whether my wound is not decreasing. So I might reassess myself. I need to look at all these parameters and see what best I can do for this patient and change my line of treatment. Still in next 2 or 3 weeks, after changing my treatment, that is 6 weeks, the wound is still not healing, I might need, I'm doing proper debridement, I'm giving proper, even circulation is proper. I've discussed this with my vascular surgeon, he has done some procedure, even if the wound is not healing, because we know diabetic, it is a distal diffuse disease, triple D, DDD. So sometime after doing the vascular, Dr. Rahul Jindal will agree with me, sometimes the perfusion down the ankle joint is not proper there. So that time I might need my adjunctive therapies. That could be one hyperbaric oxygen therapy, but now there are some data against that hyperbaric therapy doesn't help in that. So I can go in for my topical oxygen. I might, if the bone is exposed, I might use a dermal matrix. There are a lot of dermal matrices available. I might be using that. I'll go in for a PRP. Even after doing a endovascular surgery, the toe has been amputated, say for the first MTP joint, and there's a wound over there, it's not granulating. I might use PRP. I work vice versa. Take patient's blood, centrifuge, put in the growth factor. PRP is nothing, I'm putting in the growth factors which are in the peripheral circulation, or stem cells, or other therapies are there. So that type of technology I might use if my wound is not healing. Adjunctive therapies, I'll just say not to be used, and I think I open this question to my panelists also, not at the day I see the patient, or day 1, day 2, day 5. Sometimes I've seen doctors, patients have been referred to my center from other centers, and they have been used adjunctive therapies from day 1 and the patient is not healing, and that's increasing the cost to the patient. We really have to see the cost. Start from the basics, we have to see, but the basic thing, debridement, offloading, proper cultures, biofilm. Biofilm is a big problem, we all know. I know people just taking cultures from the surface of the wound. That's improper technique. We need to educate normal people, diabetic foot specialists, or some paramedics how to take cultures. That's what we do in our workshops. So these are the proper parameters we see. But yes, adjunctive therapies have a role if 6 weeks down the line, my wound is not healing.
Please. Yes, Dr. I think amongst the adjunctive therapies,